Greeting from Paris. I'm Dr. Elie Azoulay from the St. Louis Hospital, and I have 12 minutes to provide you with basic information on thrombotic microangiopathies. We are, these are my disclosures, and we are dealing with a microvascular thrombotic disease. This is the association between hemolysis, the presence of schistocytes, which are actually red cells that are fragmented on the blood smear, as well as purpura. And we have ischemia of the major organs, mostly the brain, the heart, but also the kidneys and many different organs. This is thrombotic microangiopathy. When we are dealing with a TMA, thrombotic microangiopathy, we have to understand whether it is a TTP, thrombotic thrombocytopenic purpura, a atypical HUS, hemolytic and uremic syndrome, or a STEC HUS that is usually a disease that affects the children but may be present in adults. To go there, we have different formula to understand whether we are with a TTP or not. And the COPO formula is the most used one. It is based mostly on the presence of acute kidney injury and how deep is thrombocytopenia below or above 30,000. When a patient has below 30,000 and the presence of acute kidney injury, it is very likely that there is no TTP, but we are more into HUS. Of course, this is only a formula, but when we have the patients in the ICU, we must deal with the medical emergency. Dealing with the emergency saying that we have within 4 to 6 hours of ICU admission to provide the patients with a plasma exchange. Plasma exchange in TMA, which is most likely to be a TTP, includes 60 milliliter per kilo of plasma, and the plasma has been, the exchange can be either done using a filtration with an ICU machine or a centrifugation. But we in the ICU, we used to do it with a filtration machine. We also did an immunosuppressive therapy that includes steroid and rituximab, first line, just after the first plasma exchange. And we are also providing the patient with caplacizumab, which has been recently approved for a TTP. As you can see here, the level of evidence for plasma exchange is very high, with a randomized control trial published by the Canadian Apheresis Group in 1991, showing a benefit in terms of increased survival in patients receiving plasma exchange as compared to patients receiving infusion of plasma. Moreover, when we are dealing with ICU patients, you can see that the evolution of organ dysfunction is more favorable in the group receiving plasma exchange than in the group receiving plasma infusion. And along this line, when we are going to understand who are the patients who died at the very early phase of TMA, we are with patients for whom we missed the realization of plasma exchange. So it is an emergency that should be performed within 6 hours of ICU admission, and we need to provide a PEX plasma exchange with 60 milliliter per kilo of plasma, which is around 1.5 blood mass. So now we have dealt with the medical emergency. We have managed the thrombotic complications like the brain dysfunction. Some patients are doing epilepsy. With the heart dysfunction, and some patients have cardiac ischemia, some have a level of acute kidney injury, but now we need to understand whether we are more into a TTP or a HUS. For TTP, so we have a kind of a diagnostic workup that takes into account the clinical evidence, has to perform the diagnosis of TMA and to exclude other causes of TMA, like DIC in sepsis, for example, or any drug toxicity. And then we are with 3 different situations: TTP, atypical HUS, or STEC HUS. And the landmark biomarker for TTP is ADAMS13. ADAMS13 is a green snake in this slide. As you can see, in a normal situation, ADAMS13 is going to cut the von Willebrand factor to make it shorter and to have it less with aggregation of the platelets. So you can see that the green snakes make that the blue Wilbur factor is shorter. In case of missed Adams 13, we have a TTP, and you can see that the snake is not working anymore, and we have aggregation of the von Wilbur factor with the platelets, making a thrombosis of Wilbur factor and further ischemia and end organ damages. So you can see that the major therapy that we are providing to the patients are the PECs. There is a randomized control trial showing the high level of evidence. There is the immunomodulation, and for rituximab and for steroids, there is a very strong level of evidence, but these are not coming from randomized control trials. And we have the clapacizumab that has just been approved a year ago for the disease, making that this is how we are treating the patient. PECs, steroids, rituximab, and clapacizumab. These are the two trials that have allowed to release the clapacizumab for patients with TTP, and you can see that the two trials that were pivotal for the release of the drug showed not only that there was a fastest normalization of the platelet count, but also a reduced in the number of PECs performed to achieve remission. This is how we are now using clapacizumab first line for every patient. Whether we should consider doing only for the sickest patients needs further trials. And this is the study that has allowed the first line use of rituximab in these patients. And you can see from the paper from Mary Scully that we are actually in a disease where we are comparing patients receiving first line rituximab to patients receiving latest rituximab. We have time to remission and control of the disease that is much improved. Remission will be most fastly obtained with rituximab, so that rituximab increases remission shortly and long-term after its use in patients with TTP. Out of Adams 13, we have the atypical HUS that is not related to Adams 13 deficiency, but to a complement-mediated disease. There are many different forms. AHUS poses the problem not only of acute organ dysfunction, but also long-term evolution with long-term renal insufficiency, making that most of the patients, if they are not treated correctly, would require a treatment or even transplantation for AHUS. So we know that the blockade of the complement system is the key factor that has improved not only the control of hemolysis, but also the renal function. As you can see, these are early data showing that in patients with AHUS, you can also have neurological and cardiac involvement, but all the patients had acute kidney injury. We are dealing with hemolytic and uremic syndrome, so uremia is constant in these patients. This is an autopsy study showing that all the organs were actually involved in HUS, and these are the data very convincing that reports that long-term outcomes in adult patients with AHUS are very grim, mostly in terms of renal dysfunction, making that early interventions are in order as to be able to reverse the complement-mediated disease. So once the disease is confirmed clinically, so you have a TMA, you have an acute kidney injury, Adams 13 is going to come back normal. So then you are going to provide patients with vaccination against meningococcal disease A and B. You are going to give antibiotic and to start eculizumab. Eculizumab has been validated, as you can see here on the right part of the slide. It is a C5 complement blockade, making that patients will have, this was the early open label single arm trial, showing that there was an increase, a very short increase in platelets and a stabilization and then improvement of renal dysfunction. And this is the paper from Christophe Legendre and co-workers that are two cohorts that were reported with PECs observation followed by eculizumab. And as you can see again, we have a strong benefit in terms of hemolysis control and kidney dysfunction. So the key points of my presentation are that we are in a diagnostic challenge. We can't delay diagnosis and treatment because it impacts on survival. We can have sudden deterioration, so these patients need to be in the ICU or in an ICU environment. We need to have access to resuscitation facilities, renal replacement therapy, plasma exchange, and maybe more. We have new treatments to improve outcomes in these patients. We need to have a basic diagnostic workup to improve the way we can make the difference between the different entities. We need to manage organ involvement, to treat the patients within hours of ICU admission, to work with other specialties, and to follow the patient for a long term. Thank you very much for your attention.